Hello, my name is Dr. Carlo Renato, and this is Module 9 of our 10-part series. And this module, we're going to be covering cervicogenic dizziness. And it's a topic that if you spend any time around neurologists, ENTs, even medical doctors, it depends where you are, may all be reluctant to say that cervicogenic dizziness is actually a true entity. Most often people will ignore it and say that it is not a true diagnosis. But according to the international societies and classification societies of vestibular disorders, it is gaining more and more acceptance as a true entity. Despite people believing not to be. Those of you that are manual practitioners and in practice will see very readily the relationship between the cervical spine and someone experiencing dizziness. And there's probably no better field or injury, I should say, that projects this than whiplash. Any one of us who've treated patients that have had whiplash injuries, whether it be from motor vehicle accidents, sporting injuries, falls, or otherwise, will see the correlation between and the association between cervical joint dysfunction and someone experiencing dizziness in the absence of any known inner ear or brain condition that can contribute to dizziness. So in the absence of anything vestibular based like BPPV or a neuritis or other vestibular based conditions, in the absence of those sorts of conditions, a dysfunction neck can contribute to the symptoms of dizziness. And I see it very often in practice, and I'm sure many of you who treat people with cervical joint dysfunction has seen a correlation with the presence of cervical joint dysfunction and the presence of symptomness, as well as the improvement in spinal joint dysfunction and the improvement in the symptoms of dizziness. So cervicogenic dizziness is a term that is defined by the presence of dizziness of any sort, and that can be disorientation, lightheadedness, not knowing without, not necessarily the sense of vertigo. And remember, vertigo is the sense of spinning. So often when someone says they're dizzy, that relates to the neck, they're not normally talking about the type of vertigo that they experience when they spin. Dizziness is the sense of disorientation or instability, unsteadiness, lightheadedness, and that's the type of symptoms that are associated with cervical joint problems. So they experience these symptoms as well as typically cervical joint problems, and they can include pain on movement, restricted joint function, palpable lesions in the neck, and any of the other diagnostic tests and indicators that we've spoke about in the previous modules. So there's no definitive, it's important we do acknowledge the shortcomings of this diagnosis in that there are no definitive tests, and it's typically a definition or a diagnosis made on exclusion. So what I mean by that is there's not a test or a series of tests that says 100% this person has cervicogenic dizziness, although I will show you some tests that are strongly related and can give you a very good impression of diagnosis. But also you need to be aware that you do need to exclude other causes of dizziness. So typically someone will be given a diagnosis of cervicogenic dizziness when they have cervicogenic related symptoms and they have an absence of any primary vestibular disorder. Okay, so there are some good white papers on that, and I've listed one here by some very big names that I would encourage you to consider. So the other thing we need to consider with cervicogenic problems is that we know that there are many causes of it. And so it's important we go through an algorithmic or a triaging type of mechanism to determine what the source of dizziness is. And again, you've heard me say this, the success of your treatments and outcomes will be determined by the accuracy of your assessments. And this is certainly one with cervicogenic dizziness or the presentation of dizziness that you don't want to get wrong, because it could be an inner ear problem, it could be a brain-related problem, it could be very much a sinister pathological problem, as well as a relative benign condition like cervicogenic dizziness. So, but that will only happen with accurate diagnosis. So when we have this algorithm here, we've got patient presents, and the question you want to ask is, do they have dizziness? If the answer is no, well then obviously it's unlikely to be cervicogenic dizziness. So CGD is cervicogenic dizziness. If they're saying yes, they have dizziness, the question is, do they have any neck-related issues? If the answer is no, then it's unlikely to be a cervicogenic dizziness. They have dizziness for other reasons. But if they have dizziness and they have some cervicogenic problem, then we need to say, okay, the neck is related here. Is it a serious neck-related problem, or is it a benign-related problem? So the next question we want to do is we want to go through, and you should be aware of the Canadian C-spine rules. And basically what it does is it rules out the likely presence of serious cervicogenic pathology, whether it be malignancies, dislocation, fractures, or otherwise. I'm not going to cover this Canadian C-spine rule here, but I encourage you to do that at your own accord. But you do need to go through that. Most of the time that will come back clear. So now we've got presence of dizziness, we've got presence of cervical joint problems. We don't have any serious cervical joint problem, so what's next? So then we check the cervical range of motion. If when we do our test, we're seeing signs of cervical joint instability, then we do need to be concerned, and we may need to refer on or take some images, some functional images that can rule out the presence of any cervicogenic instability. Now again, that's relatively uncommon, but we do need to check that. If there is no instability, we do a neurological test. And again, now we're looking for any cerebellar signs, any cranial nerve testing. And if they're showing abnormal cranial nerve or cerebellar signs, it's probably the time that we refer on or do further investigation into the reasons why they have that. Okay, so if that neurological screen is fine, then we do a vestibular assessment. And the vestibular assessment can be positional, head positional, oculomotor, other vestibular tests. Again, we can spend a lot more time on this when we're together. But if that is abnormal, then you certainly need to refer them to the appropriate dizziness or vestibular rehabilitation specialist to get that further evaluated. But if that's within normal limits, now we do a detailed cervical joint assessment, and that will include our motion and static palpation. It will include our deep cervical flexor work. It will include our cranial cervical flexion rotation test. Again, go back to the test that we've done in the earlier modules, and they are now appropriate to determine. And what you're likely to find is, in the absence of any of those vestibular instability or serious pathologies, you're now going to find the cervical spine dysfunction to be the primary cause why this person has cervicogenic dizziness. Okay, and then we do our test, which can include our neck torsion test, our relocation test, and our kinesthetic test. Again, things that we've done to date. So this is a great algorithm for you to use that's evidence-based and is safe and methodological methodological, that didn't quite come out, and that's a reason why you would use this sort of test. Now remember, with cervical joint dysfunction, we need to be aware if there's any history of concussion or whiplash, because very common in both of these, in both whiplash and concussion, which is really essentially the same mechanism at play, that cervical joint will be impaired, and dizziness is a very common probably a very common symptom following a whiplash and concussion, and it's often a symptom that, if present, tends to indicate a more severe injury at play. Okay, when we have concussion or cervical joint injuries like a whiplash, we get not only disruption of our neck cervicogenic proprioceptors, both in the muscle spindles and in the Golgi tendon. We can get cerebellar and brainstem and deep cortical structures being injured as a result of that, as well as primary vestibular disorders. So these sort of conditions can arise and can contribute to someone's dizziness, because each of these, whether it be the brainstem, the cerebellum, the vestibular system, or deep cortical areas, if they are injured, they can also give or contribute to the patient feeling dizzy at some level. So they may have cervicogenic, but they also may have brain or vestibular basis to their dizziness. And concussions, as mentioned, can mimic and look like whiplash injuries. The differences between concussion and whiplash injuries are very difficult to separate and to isolate. They do look the same. So if someone's hit their head or they've fallen, you need to consider that they've got either a whiplash and or a concussion until proven otherwise. All right, so things like headaches, dizziness, tinnitus, sleep disturbances, blurred vision, cognitive issues, balance issues are all very commonly associated with both of these. Now, we've seen this before where we've looked at altered sensory integration. When the cervical joint gets disturbed, it has a flow-on effect to the central structures, and they also include our vestibular, oculomotor, higher cortical, and balance. And each of those will give the impression of instability and altered position. And that altered position and instability people will say, I feel dizzy, I feel lightheaded, I don't feel very stable. So be aware that this is often the reason that underlies why someone has a cervicogenic contribution to dizziness. One of the things they'll often say is that they'll feel this disconnection. They'll feel disorientated, lightheaded, floating, swaying, and rocking. So when they say dizzy, they can say any of these words and they will be referring to dizziness. So they do give you different bits of information as to the whereabouts of the cause of dizziness, but the fact is that it's all lumped in as under the umbrella of dizziness. So they'll also say that they feel a sense of lost, they're not grounded, they're fuzzy in the head, and because of that disorientation and instability, they'll often have fear, hypervigilance, and be anxious. When we look at to be able to differentiate between various forms of concussion, physiological is sort of the head trauma. Vestibular ocular is when it affects those structures. Cervicogenic, obviously, it's of cervicogenic origin. Now, the differences between these and the way to differentiate them is this graded treadmill test, and what they refer to as the Buffalo concussion treadmill test. Those that have a true concussion will have poor test results from this treadmill test. Those that have got a vestibular or a cervicogenic will not have an abnormal treadmill test. So it's a way to differentiate where the concussion or where the dizziness is coming from. when looking at cervicogenic issues, these 5 tests have been shown to be the best test to help identify cervicogenic primary dizziness. And they include the cervical joint position error test. And we've done this. This is the one where we use the laser on the charts and we're repositioning our head to center. We have the smooth pursuit neck torsion test. And again, we've done this where we're looking at the ability for a patient to follow a smooth pursuit, and we're testing with the neck torsion at 45 degrees, and we're doing that in different directions. The head neck differentiation test is otherwise known as the cervical body awareness test, or the differentiation test, where they can turn their head, keep their head still while they're turning their torso side to side. So they're keeping the head still whilst their body is turning from side to side. And that disassociation test or differentiation test is a great one to do. The other one is the cervical flexion rotation test. And again, we've done this where we raise the head up and we flex the cranium on the cervical spine, and we look at the amount of rotation from left to right. And the last one here is looking at the deep cervical flexors and deep cervical extensors. And we do that with the blood pressure cuff. Now, we've covered all of these, and all of these tests are functional tests that look at cervicogenic function. And when these are aberrant, they can contribute to cervicogenic dizziness. So the 3 tests the literature supports in being able to identify the cervical spine as a contributor for dizziness is the cervical spine joint position, the smooth pursuit neck torsion, and the last one is the cervical rotation test. Now, the cervical rotation test is otherwise known as the Fitz-Ritson test. So basically you have, as a practitioner, you hold the patient's head and you ask the patient quite quickly turn their torso from side to side. Now, as they keep their head still and their body is rotating relative to a fixed head, the only thing that's really getting worked is the cervical spine. And because of that work, and if they're experiencing symptoms, then the only contributor to that is going to be the cervical spine. Because understand, my head's not moving, so it can't be vestibular. It can't be ocular because you're asking the patient to look at your nose. So both the eyes and the head are still. So you've taken out oculomotor and vestibular possible contribution. The only thing that remains is the cervical spine. So when you rapidly turn the shoulders from side to side whilst keeping the head still, and the patient comments that they're feeling symptoms or they feel dizzy compared to when the head was or the body was still, then that's a positive test to say to you that there is a cervicogenic contribution. So the addition, the combination of 3 of those, which is the cervical spine joint position, the smooth pursuit neck torsion, and the Fitz-Ritson test, can together give you a very high sensitivity and specificity to say that the cervical spine is the cause of that person's dizziness. All right. Moving on to treatment options for cervicogenic dizziness, as you can imagine, will depend heavily on the cause. We've gone through many of those different options for treating the cervical spine in these modules up to now. But I guess just to summarize it, some of these, we do need to consider oculomotor. We spoke about the relationship between the eye movements and the upper neck. And so we may need to consider some smooth pursuit or optokinetic or saccade type of exercises that aren't just necessarily in a neutral position, but may be in a neck torsion position. So we spoke about some of these different eye movements, but normally in a head neutral position. If we find that head rotated to the left is contributing to dizziness, then it's important that you provide exercises which may be eye movement exercises, smooth pursuit, vertical, horizontal, saccades, in that cervicogenic dizziness provocating position. So if their head's turned and they get dizzy, well, you may want to do some of the exercises in that position, because that is a very specific, targeted avenue that will often give you better results than doing it in a neutral, ideal position. We may want to do cervicogenic proprioception. So again, we spoke about the joint position retraining or the body disassociation. Well, rather than just do the tracing or the relocation with the head in a neutral position, you can do it with the body turned. So they're still facing the chart, they're still doing the head position, but now the body is turned in a direction that would typically give them symptoms. So they're saying, okay, well, this position I don't get any dizziness, but when my head's turned to the right, I get woozy, dizzy, and so on. Well, that is telling you that they may well need to do some joint position retraining and some biomechanical type of work with their neck in that position-provoking position. Okay? Body biomechanics, cervicogenic mechanics. So again, we can do some soft tissue work, some instrument assist work, some manual therapy. And again, don't just do it in a neutral position. Consider the position that their body is in that is causing some of their symptoms. And I would try to treat the patient in that provocative position. You will find greater results, particularly to those that have had stubborn or long-term symptoms. Obviously, we've got vestibular, we've got peripheral-based vestibular issues, benign paroxysmal positional vertigo or BPPV. We've got central disorders, we've got other peripheral disorders. This is not the place to go through the vestibular components to it. We've already covered parts of it, but understand that you really do need to understand that vestibular system, because it will make a big difference to the success of cervicogenic dizziness. We've also got balance and gait. So, you may want to add balance and gait therapies and add these type of exercises to your other treatments that you've added to date. Then we've got our pain sensitivity. You may want to do some of that trigeminal desensitization procedures that we spoke about in our last module. You also want to look at maybe some structural areas around the upper back and the neck and the shoulders. And you certainly want to consider anxiety and stress reduction protocols, maybe working with a counselor or with a psychologist, because we know that when someone is anxious, hypervigilant, and fearful, that they're likely to get symptoms like dizziness more often just because of their anxiety. Remember, dizziness is not just a structural component, there is certainly an emotional aspect as well. So the practitioner that either appreciates or refers on to the appropriate people when these patients present are the ones that are going to get the best results. So all of these things here potentially and often in combination need to be considered in treating someone with cervicogenic dizziness. So this is module 9, and we've just completed that now, and we have one module left, which is the integrated management, which really pulls together all either make sure you register for them or you review those before we do our final module. But until then,